Hello, everybody. My name is Lauren Thaman. I lead communications for P&G Ventures. P&G Ventures is a startup area within Procter & Gamble, and we're charged with creating new brands and businesses and categories where P&G does not play today. We're here to talk about gender inequalities and women's health. And I am very, very excited to introduce this wonderful panel. And I'm going to let them introduce themselves, but next to me is Beth Battolino, oh my gosh, I'm so sorry. Beth Battolino, and then we have Dr. Allison Mcgregor and Dr. Lisa Larkin. Beth, why don't you share your background, and then we'll go down the line.
Sure. Hi, I'm Beth Battolino. I'm president and CEO of Healthy Women, a company that are a national not-for-profit. We are the largest national not-for-profit women's health organizations that I restarted in 1997. And we're solely dedicated to women in the middle, that women 35 to 64, and I'm so pleased to be part of today's conversation.
I'm Allison Mcgregor. I am an emergency medicine physician, and I am the co-founder for the Sex and Gender Women's Health Collaborative, which is a national organization, and then also a co-founder for Sex and Gender in Emergency Medicine at Brown University. Currently, I'm the Associate Dean of Clinical Faculty Affairs and Development at the University of South Carolina School of Medicine, Greenville. And I'm the author of a book, Sex Matters, How Male-Centric Medicine Endangers Women's Health and What We Can Do About It. And I'm thrilled to be here. Thank you so much.
So I'm Lisa Larkin. I'm a women's health internist who's been practicing in Cincinnati for 30 years. I'm also founder of a company I started about 2.5 years ago called Ms. Medicine, which is specifically intended to advance women's specific health care, particularly in midlife and beyond. But this is a topic that I am very passionate about, and I'm really honored to be here talking about this today with my esteemed colleagues, so thank you.
So welcome. I'm so glad you're all here because I'm really excited to hear all what these wonderful participants have to say. And when I was doing the research to get ready for this panel, I found a really interesting quote from Aristotle that said, "Females are the inverse of the male body. With its genitalia turned outside in, women are defective." And I'm like, well, that surely didn't set up really healthcare in its best light. But other than Aristotle's point of view, why don't you share with us what do you think the real systemic issues right now in healthcare is for women? Beth, you want to start?
So I think,
Just leave it on.
sorry. Well, yeah. No, I think overall it's just right now, so from a consumer perspective, and that's where that's gonna be my area with Lisa and Allison, is I just think with women right now, we're underdiagnosed, right? We're putting ourselves last on the list. Women are not, we don't prioritize our own health. Everyone comes before us, and there's still that long diagnosis. It's taking us, like for cardiovascular, even endometriosis, 7 to 10 years to get a proper diagnosis, which is unacceptable in 2022.
Sure. I think one of the major problems here is the fact that this gender bias that we're talking about, is the title of the panel, is really systemic throughout our entire medical system. So we mentioned cardiovascular disease. If you just look at the #1 killer for both men and women, and it's heart disease, but women are less likely to be diagnosed. They're less likely to be treated. They're less likely to have a life-saving intervention, and they're more likely to die in the hospital before they are even discharged than men. And so when we think about that, and we actually look at that type of real-life data, the systemic bias actually really, it's very complicated and intricate. It starts with our understanding of science and research. And since our understanding of science and research has been based on enrolling men in clinical trials and studying male animals, that has been our framework for understanding health and disease. And then we've taken that evidence and we've used that to teach our doctors, to teach our nurses, to teach our pharmacists and our dentists. And we are now in a healthcare system that is looking for male patterns of diseases and male-centric treatments. And the result of that is women are not getting the right treatment.
So I can jump right in and frame it maybe a little more simply. So as a practicing, clinician who has a busy practice doing primary care and consultative women's health, and as a breast cancer survivor myself, I can tell you that we are just simply failing women, particularly midlife women. And there's so many, like with any major problem, right? It's never just one simple issue and it's never one simple solution. And as you've heard already, right, there's lots of research gaps that we have. There's lots of societal issues where women really at midlife especially are so preoccupied with taking care of everybody else and potentially at the peak of their career that they're not taking care of their own health. But the bigger issue, or one of the major issues that I see really as someone who's working in the trenches, is that our healthcare system is failing women, and we as doctors are failing women. And there's lots of reasons, but I'll start with saying that we really, if you think about how we have our healthcare system set up, it's really now based on a couple premises. One, specialty care. So we now have everybody working in silos. And what that does is completely fail women. Specifically, if you think about it, reproductive age women, younger women who are having babies, who need pap smears, who are basically healthy, they see their OBGYNs, and their OBGYNs do a great job taking care of them, and then they enter that 40-plus age where they're done having babies, pap smear guidelines have changed, they're not seeing their doctors very much, they don't really have health issues, they also are worried about taking care of everyone else in their family and their career, they're not really having lots of points of contact, and then they don't transition to really having a primary care doctor until their early 60s, when they're, in their early 60s when they start having health issues. And so you have this really important gap in care between like 40 and 60. And what happens then? Lots of things happen then, right? It's when women start to have elevated breast cancer risk. It's where we really need to identify women who are carrying hereditary cancer mutations. It's when women starting to have elevated cardiovascular risk and they're not getting identified. It's when women are transitioning through menopause, diabetes is developing. All of these things are happening and women aren't getting preventative care. They just don't even have enough contact with physicians. And it also goes back to this siloing, right? Which is, who owns women's health? Nobody owns women's health, right? The OBGYNs, we've often thought, and we just heard, that it's just reproductive organs that makes women different, and Dr. Mcgregor has a great talk about that, right? Women are different down to every single cell in their body. Their DNA is different. How have we thought that women are just small men? It doesn't make any sense. And in terms of how we deliver health care, it also doesn't make any sense, right? OBGYNs don't own women's health. Women's health spans the entire lifespan. And what's happened is, again, you have that really important gap when women aren't getting care, and then they transition to their primary care provider, who, again, for lots of lack of research, specifically identifying, looking at women differently than men, right? So we're not even thinking about women differently, and diseases that present in women present differently than they do in men. But doctors aren't even educated and trained. And so there's this whole gap in really knowledge, and then even clinicians aren't trained. And so we are really failing. I can tell you 30 years practicing in this space, and I can tell you things really aren't very different right now. And it is the reason I started Ms. Medicine, because I tell all my patients, on the back 9 or the back 7 or the back 5, wherever I am right now, that my last hurrah is really trying to make a difference in this space, because we have really work to do, and COVID has really accentuated that in lots of ways right now, and I'm sorry for talking so long.
No, I think, so Dr. Mcgregor, you talked about that until 1990, women weren't necessarily even involved in trials. How has that manifested out, and what does that look like, and what does that mean to us as women in our care?
Sure. So if you think about the history of medical research, women were considered a protected subject, because if they got pregnant during the clinical trial, that could result in some really catastrophic consequences if we don't understand what those would be. So that's when really women were just considered protected. Studies that really, this was the time that our cardiovascular understanding studies, our stroke, all of our big clinical trials enrolled men. And we thought that we could just use those same results and apply it to everybody. And that's, not the case now that we've discovered that. So around 1993, the Nih Revitalization Act actually said, maybe we should include women and minorities into research, and at least in the later stages. So that started sprinkling some women and minorities into the later stages, until we realized, well, we should probably do that through the whole course of our understanding of research, from cellular research, because every sex has a cell, every cell has a sex, so it's either XX or XY chromosomes, that sort of thing. And so understanding the mechanisms and the differences between men and women has been really, really astounding and interesting. One of the consequences, a flagship example, is with the drug Ambien, Zolpidem. And so what happened was Ambien is a drug for sleep disorders. It helps people sleep. And so it was on the market for over 20 years, primarily prescribed to women, because women are more likely to be diagnosed with sleep disorders. But what happened is post-market surveillance, which is really all you have for women to catch maybe that something doesn't fit right for them. Because if they're not into the pipeline, then the drug is out there, then all you can get is really reports afterwards. Well, there were these reports that were just piling up about women having impaired driving the morning after taking this medication. And so as a practicing emergency medicine physician, I think about impaired driving and motor vehicle crashes. That's real stuff. People lose their lives, they lose their limbs. It's a crisis in that particular woman's life. And so what happened was we realized that women metabolize the drug at a slower rate than men. So women should be prescribed a different dose. So they actually checked the serum concentration in both men and women, and men had 2 times the serum concentration compared to women. And so the FDA created their first sex-specific dosing regimen. That's one drug that's out in the market. We have hundreds, and amazing amount of real amazing medication that have been tested and finalized and perfected in men that are now being given to women, that have been given to women. So that's one small example that I see, every time I work a clinical shift. And we've been relying on that sort of reproductive health. Like, women have been reduced to simply their reproductive organs as their most valuable, medical value. But when I'm in the emergency department, I mean, women are there with lots of things. They're there with cancer, they're there with strokes, they're there with infections, they're there with things that we haven't really taken into account. How does the menstrual cycle affect this? How does their own metabolism? So right now we're starting to really build up on this evidence and knowing when something significant is different between men and women. And we just have to really sort of get that out there so that women can have this sort of individualized care as soon as possible.
So let's switch gears a little bit, because it's really important that we just don't know. This is what you're hearing. We just don't know. The science isn't there to really adequately care for women. But also what we're seeing is 52% of women believe there's a gender discrimination that they're seeing in their health care. So how does the implicit or even the implicit gender bias affecting health care, and what can women do about it?
So the first, from my perspective, it's, education, right? So we are our own best advocates. So understanding your family health, and we talked a little bit about this morning over breakfast, is understanding your family health, your family history, making sure that you do have a healthcare provider and that you're carving out time to take care of you, right? Keeping your annual women's wellness visit. And guess what? That's still covered under the Affordable Care Act. There's 26 preventative services that are covered for women under the Affordable Care Act right now. So keeping your preventative, your annual women's wellness visit, and we know that preventative medicine saves lives. So keeping your annual mammogram, if you're due for your Pap test, we know that's changed, but understanding when you're due, and if you haven't had one, just get one now. And then making sure that if you are not getting the answers that you want or you feel that something's wrong, then seek a second opinion and make sure that your healthcare team is a team. So if you're going to a male physician, and male physicians are awesome, I'm not trying to, but you may want a female too involved in that, in your healthcare. So making sure that if there's something not right, like women have the best, like, go with your gut feeling, right? So if something is not right and you're not hearing or they're dismissive, your healthcare provider is dismissive, then maybe it's time to change your healthcare provider.
Yeah, I saw, there was a lot in that, and I think the other thing is they talked a lot about chronic pain and how women were perceived in chronic pain. Would anybody like to comment on the bias there?
I'm happy. So yeah, so I think if you go all the way back, and I liked your quote from the beginning, you know, women through the ages have really been perceived as having this hysteria narrative, right? So if you look back, everything was related to hysteria and mental health issues, right? So specifically in the arena of, you know, menstrual cramps, endometriosis, fibroids, right? Women had real medical issues and they were perceived as hysterical. And that's really continued through all of our current medicine right now, which is we know that women really are much more likely to present with complaints and get delay in diagnosis because their complaints are taken as part of being mental health issues, right? So there's still this perception that women go to the doctor more often because of mental health issues and hysteria and anxiety, so their complaints are really taken less seriously. And so there's this delay in diagnosis, and that goes back to really kind of the chronic pain issues as well, right? So things are ignored, and the data's really, unfortunately, horrible in terms of all of this category, which is, again, just, it's so clear in so many ways how we continue to fail women because of that bias against women that just is pervasive there. And so, you know, to Beth's point as well, and I talk to patients about this all the time, if you feel like your complaints are not being taken seriously or you aren't being heard, you need to get another opinion. You need to find another doctor that really is listening to you. And in the space where I really practice a lot is in the perimenopause, menopause space. And I cannot tell you the number of times that I have patients come to see me who are kind of patted on the back and said, you know, it's menopause, symptoms are going to get better, that's really natural, like just ignore it or take some supplements, and have absolutely no experience or knowledge about the significant impact of the menopause transition and that there's treatments available. And again, it just gets blown off because of this hysteria narrative and lack of education.
Well, actually, I was sharing a story of a friend of mine this morning who kept on going to the doctors, and because she was always a very big athlete and very thin, and her waist was getting thicker. And the doctor's like, you're just so neurotic, just stop, just stop, just stop. 2 years later, she was diagnosed with stage 4 pancreatic cancer. And so these kind of things are real, and if you think back in your own personal life, you'll start thinking about them. As I was doing research for this, it became very evident that, like, I've faced the, you know, bias in my healthcare journey, and it is quite fascinating and really important. So I think educating yourself is going to be a really important place to do that, and where you educate yourself is really important. Like, let's comment on that a little bit. Like, don't go on TikTok.
Yeah, so the education piece, and that's where healthywomen.org came into play, is there is such a need for education, right? And we all know we can go to Dr. Google and you can plug in anything and get everything that you want, including recipes and you know, snake oil. So the most important thing is making sure that you get your information from credible sources, and then you go armed with that information and have the conversation with your healthcare provider. But it is really important to make sure that your information's medically vetted and that you're getting it from, you know, good sources. So just make sure that as you're and we all want you to do your research, but just go to the good organizations that you can trust. There's a lot of medical organizations that you can start with and then go from there. And then I'll just plug healthywomen.org. It's a great resource, and everything that we create is medically reviewed and vetted.
So not TikTok.
Not TikTok. Maybe for fashion, but not for medical information.
Or
Recipes.
So they said a lot that, you know, that there was a study in 2017 that doctors ask women fewer questions than men. Have you seen that? Have you seen that? As you know, in your work, or you're practicing nurses, that practicing physicians?
That
doctors ask women fewer questions than they ask men.
What
So that
is the
there's
doctor
not,
a
they
male
don't
or
not get as
female?
much evidence, they're not getting the data.
Okay.
They just, they're asking a woman 3 questions for the same condition they'd ask a man 10.
Well, I think that's also gendered, and that's been shown as well. So not only has science just thought that men were the default physiology, it's really interesting that your gender of your doctor also matters, and that relationship matters. And so it has been shown both in surgical studies, it's been shown in heart attack studies, and it's been shown in hospitalizations that when you have a female patient and a female doctor, they get better care. And I'm not saying that men are bad doctors. I'm saying that that particular connection has been proven, and it's been thought probably due to the fact that women are communicate more easily to other women, and so that may actually translate to when they give instructions and when they give feedback that it might be taken more seriously. Women are also thought to undergo more likely to follow hospital-based guideline therapy than men. And so I think the things that have been reiterated here, making sure that you are comfortable with your doctor, making sure that you have this relationship, and if you don't have something comfortable, then you need to find a new doctor. If you don't feel comfortable enough to ask lots of questions, then I think you should feel empowered to move on.
Yeah, I was reading that women typically diagnose 2.5 years later for cancer and 4.5 years later for diabetes. And I just thought that was kind of amazing, and I'm sure you guys see this every day in the work you're doing. And they also talked about bleeding disorders, chronic pain, autoimmune conditions, mental health. Can you share some of these kind of examples of why this plays out with the audience?
So I see this all the time, unfortunately, and again, I don't think the problem is singular. As I said earlier, right, so lack of training and lack of education in women's specific health issues is one of the key things and one of the most important, I believe, initiatives that we have to take in terms of training clinicians is really doing a better job focusing on sex-specific, women-specific guideline developments and just education of care. The second thing is the siloing of care, as I mentioned, right? So this fragmentation and super specialized care really harms women because, again, no one owns women. It's not a one specialty thing. We need to provide sex-specific care across the lifespan. The other thing goes back to women don't present early enough with their symptoms. They don't advocate for themselves enough. They're not pushy enough. They don't see the doctor. And again, they kind of get this gender bias in terms of being blown off early, which is what we're seeing all of these delays in diagnoses. And I cannot tell you how frequently I actually see it. So again, one of the most important things I hope you walk out of here today is that you really prioritize advocating for yourself, and that again, if you have symptoms, that you continue to seek to get help until you really feel like you're getting validated answers. The one thing I'll add too is, one of the interesting things that's happening in healthcare delivery right now is you probably know that, primary care specialties are the lowest paid of the healthcare specialties. So being an internist or a primary care family medicine physician now is really poorly compensated compared to all the procedure-based specialties. And in fact, my daughter just graduated from medical school, and she said, I would never do what you do. You work way too hard. And her father is an orthopedic surgeon, and he doesn't work as hard as I do and earns 10 times what I earn, right? Like the disparity in compensation, depending on the specialty in medicine, is so wide. The problem for that, for healthcare going forward, to everybody in this room and to all of your sisters and parents and children and aunts and everybody, is that we actually really need good primary care, because your primary care provider is the only person that's really supposed to be integrating all of the data and the specialty care that you're getting, so that you can synthesize that and you have someone that's a captain in your ship. But what's happening now in our healthcare delivery is we are still de-incentivizing doing this comprehensive primary care, where you require thoughtful shared decision-making about complex issues, and making treatment decisions, and we incentivize the specialty care where people are doing procedures and things to you, right? So you can get your colonoscopy and your angiogram and your bypass surgery and have your gallbladder removed, but we really haven't figured out how to appropriately incentivize people to do high-quality primary care, which is really what we need, because that's what the majority of care really needs, and it's part of the problem for how we're failing women and men.
So Dr. Mcgregor, can you give us an example? I know Dr. Mcgregor is involved in this documentary called Misdiagnosed, which we're going to try to show at the end. So give us an example just on heart attack, how it manifests differently in a man versus a woman.
Sure, absolutely. So we were taught in medical school that a heart attack looks like a white man clutching his chest, saying that he has an elephant sitting on it and it radiates down his left arm. This still is perpetuated. It's still in the books. And we were then taught that women are protected from having a heart attack until they reach menopause. And that's false. That's not actually true. And so women have heart attacks. They have different forms and different types of heart attacks, and they can have them when they're young. So what happens is, as a physician, I'm looking for pattern recognitions. What does it look like? When should I think about a heart attack in my patient? And so when you have a female and she presents with fatigue for a week or two, nausea, a little indigestion, or shortness of breath, which are the three more common symptoms that women will have, we don't know what to do with that, right? We weren't taught that that could be a heart attack. And so we say, you can't have a heart attack. You're only 40, and this is what a heart attack looks like. So why don't you go see your gastroenterologist? It might be the reflux, that you have GERD, or this could be your anxiety. It's probably a panic attack. Why don't you see your psychiatrist? Just like we were saying with all this specialty care, women are constantly sent to someone else to look for to what's causing that. And really that relates down to the fact that we haven't studied these diseases, autoimmune conditions, chronic pain, fibromyalgia, all of these syndromes. Syndromes is just a collection of symptoms, right? It's not really a diagnosis. We don't know what's going on a cellular level. And so I worked with the Emmy Award winner, documentarian Trisha Regan, on a documentary called Misdiagnosed. And she really follows several women through their misdiagnosis of cardiac conditions. And then I was fortunate enough to be the doctor of the piece that could really sort of discuss how this happens to women. And it's a really powerful piece. So I hope you stay for the trailer that we're going to show at the end. It's really wonderful. But it's just highlighting the problem, which is large.
It is a big problem, and I think it's, and I did share earlier that I have a daughter with celiacs, and she's tall and thin. She's 5'11" and wears a size 4. And every time she'd go to the doctor, she'd complain about always being sick to her stomach and this poochy stomach. And they just kept on telling her she was vain. And so for 7 years, she was going to the bathroom 7 to 12 times a day, and they're saying that's normal, until finally one doctor looked at her and said, that's not normal, and was diagnosed with severe celiacs. And it's just, we have to be our own advocates, and we have to keep on saying, this doesn't make sense, right? When you think about doesn't make sense, you think about education of physicians, and we talk about education of the consumer. When you see the consumer, what kind of content are they most likely to want and receive? And I know you're putting a lot out there. Great.
We're putting, what's really trending strong on Healthy Women, and it has for a while, is real women, real stories. So showcasing and doing the interviews of women living with, right? And hearing their stories. And then more importantly, hearing how they're living well with. So they're, interviewing them, understanding when they got, what their signs and symptoms were, how they got diagnosed, and then what's working for them. And it's sharing their story. And that has been one of our that's been doing extremely well, and it makes sense the way that we're receiving information today. It's just, you want to hear the good, right? You want to hear you want to hear how you got diagnosed, but you also want that silver lining, like, what can I do to help improve and get better and live successfully with? And I think that's the part, you know, I've been in women's health for over 20 years now, and I'm looking at the timeline, and yes, there's still so much that we can do, but I look at when I started in women's health, which was right after college in the 90s, and it's just, I've seen such a great improvement in women's health. There's still a lot more that we need to do, but it's so much better than where we were, you know, 10 or 15 years ago.
What is the role of technology in women's health?
Well, it's instantaneous. Like, it's crazy. I remember I used to answer the phone and write down. Like, people, I was like the time life operator, where people would call and I would write down their, you know, what they were looking for. And I would go and do the research and broke every copyright, you know, law. I would Xerox and then send them like a package of information, because there wasn't a lot of women's health information in the 90s. Remember, there would be like one column in Cosmo or the magazine, and then finally you saw like the morning shows doing like, they would do almost like a series. You would see Katie Couric, now I'm going to date myself, and then Ann Curry. They would do like a series on women's health. And then you saw the magazines start creating like women's health sections. So it started to evolve. And that wasn't until the 90s and 2000s, which is crazy, right? To think that women's health used to be one column in the early 90s and then became women's health section and women's health series. But you know what's interesting? You still can't say vagina on television. We can talk about erectile dysfunction, but you cannot talk about uteruses or vaginas during primetime television. I still find that interesting. But going back to your question, like how is technology improving women's health? I think it's improving health on the way we're receiving information and how we now can, especially when we look at mental health and telemedicine, it's improving access, right? Because not all of us have access to some of the healthcare providers that we need and or the time. So telemedicine is opening that doors for people that live in rural areas. And I think that, and the access issue it's helping to improve technology.
If I could just also comment, and I totally agree, which makes it wonderful. But we should also make sure that we look at, in our technologies, who is writing the code, okay? Because that really matters, right? There was this one study that looked at smartphones, and they had 4 or 5 smartphones, and they asked the smartphones questions, and they asked physical questions. Hey Siri, I have chest pain, or I have a headache. And Siri would say, would you like me to call your doctor's office? Would you like to know where the nearest emergency department is? And then when they asked it mental health issues or issues related to that women might have, I'm depressed, I was raped, it didn't exist. There was no response. I'm sorry, can you please say that again? Or I don't know, I can't really comment. And so what they looked at is they look at who is writing the code. So I think there's a great chance the more we have women in leadership positions in STEM, science and technology, the more that they're involved and being able to be leaders, women think of women. And so I think that's really important to advocate for both that, from both the employer, employees, and career choices, because it really does affect all these health products as well.
Before I go to Dr. Larkin on the negatives of technology in our use.
I was going to say, do you want me to
She's on the edge of her seat. But I will tell you that we do, one thing we know, we work in the startup community, and P&G is interested in looking for startups in fast-moving consumer goods in women's health space, because we're really interested in women, Black and Latinx entrepreneurs, because we know people solve problems typically that they have. So before I go, okay, Lisa, what are the downsides, or Dr. Lecker, what are the downsides of some of the technology?
Well, so first of all, I don't want to contradict anything that my esteemed panelists said, because of course, like anything, it's a double-edged sword. And I think all of us who have, I come from the dark ages. I'm old, and so, I still, when I was on call, I had quarters, and I used to stop at a payphone to make my calls, right? I typed my medical school applications on a typewriter, right? That's how old I am. But You know, technology has brought incredible advances and benefits to all healthcare and specifically women's healthcare. So I am not here to totally slam it, but it has become the wild, wild west. And I do really see negatives, significant negatives. And I can give you lots of examples, but what I would start with saying is that because I really take some ownership in this space of how our healthcare system really is failing women and men. We have a really broken healthcare system. And when patients, women and men, fall through the cracks and they aren't getting their needs met from traditional healthcare, they go outside of the traditional healthcare system. And so what's happened in the world of technology and social media and in the startup space is, in many ways, business and medicine are not really good bedfellows, right? You take vulnerable people who aren't having their healthcare needs met, and you can sell them anything. And there can be a lot of snake oil out there and a lot of not good sources of information. So I really agree with Beth that if you're searching the internet, you really have to look at where your content is coming from. But there's a lot of people in the space who are taking advantage of, and I was telling them at breakfast some examples of some really egregious things that I have seen going on in the market space, in the healthcare market, and so it's just a little bit consumer beware in the space. And again, not to completely, because there are really advantages, and I think, again, there's lots of good things happening. It's just not all good.
Yeah, we were talking about the advantages and disadvantages of telemedicine. And so while telemedicine has been awesome, particularly during COVID, for you to have access to your doctor, or people in rural spaces to have a relationship that may always be on Zoom, right, to their physician, particularly a mental health provider. There are a lot of telemedicine that is not designed for the medical professional. It's really designed as a revenue provider, and that's...
So I'm going to jump in here and just really, this is again another one of my soapboxes I can get on, but so where we really as a society need to get to is developing language around what is telemedicine. Because everything that you're hearing about telemedicine is not all the same, right? So telemedicine can mean many things. If you have an established relationship with a doctor, a primary care provider, or a specialist even, there may be many circumstances where telemedicine is a really great thing to provide care. There also may be many circumstances where telemedicine in a vacuum, and menopause is one of these spaces where there has been some growth in telemedicine, where you can do virtual visits with a doctor who you don't know, who isn't your primary care doctor, who really you have no ongoing relationship with, and that may be okay. We don't actually have data that that's okay, because where I've seen it fall apart, and this is where, again, you have to know who you're having a virtual visit with in telemedicine, is delay in diagnosis, misdiagnosis, and when there's problems or the telemedicine doctor is not able to help you, there's no ability to refer you because they're not based in your community. So where I've seen it really fall apart is there. The third thing is the companies that are describing telemedicine that really aren't telemedicine. What it really is selling prescriptions. These are really e-commerce pharmacies who are having doctors do quote-unquote telemedicine, where it's really, and I've secret shopped all of these companies, where it's really bot questionnaires, where you can get a doctor who is licensed in your state basically signing off on something, so you're getting mail order prescriptions. And again, where it becomes concerning to me as the practitioner, right, and I, secret shopping them, have had offers of prescriptions being prescribed for me which counter or interact negatively with one of the medications that I take. It's just, again, there's really been no data yet to decide when are these things really appropriate, when are they good, and there are really good things about it, to Beth's point, because we can get specialty care into communities that don't have access for low cost, but we don't have any data yet to decide when it really works well and when it doesn't work so well, and when we potentially are putting people at harm. And so again, I think we need better language around really what's telemedicine, good telemedicine, not good telemedicine, and what's really e-commerce prescribing.
So there's I'm going to ask one more question, and then I'm going to ask one more question, then I'm going to open up to the audiences for questions. But how do you think we can inspire a movement for change? Who wants to go first?
I can go first. I love that question. And I think we all have a sphere of influence. So if you are, you run a book club, you run an education committee meeting, you're a CEO of a company, whatever it is that you have a sphere of influence over, I really invite you and empower you to bring this topic up. You know, make it something that, that becomes an aha moment, because a lot of this is really based on awareness. Most of the public thought that we were doing things fairly, and are shocked when they find out that it's not. And so the more awareness, I think, the better. Also, when you are talking with your doctor, ask questions. Be empowered to say, hey, you know this drug that you just prescribed me? Was this studied in women? Because I'm a woman. Is there something I should know about the side effects that are specific to me? And that doctor may not know, right? But what are they going to do? They're going to look it up. And so now you've just educated, you know, from your sphere, from your influence. So I would really just invite you to whatever influence that you have to sort of bring awareness to this.
Well, so I'd love to comment, of course. So where I see huge opportunity, one of the reasons I'm so excited to be here is because the interface, again, not all technology is bad, but in the technology startup space, young individuals with new ideas and new ways of doing things, really interfacing with those of us that have the years in the healthcare experience, or years in the healthcare delivery, and as physicians really seeing what's still going on down in the trenches, where there's really opportunity to interface in a way to really advance change. Because I can tell you that, I know, Beth, you think that you've seen a lot of progress. I can tell you I really haven't seen the progress. When I'm sitting in front of patients now, I'm hearing really the same thing that I saw, and I use hormone therapy as the defining journey of my entire 30-year professional career, and we've been all over the map with that. And the truth is there's still just such incredible lack of information and lack of information getting to patients and to doctors that I just see that we are still, there's such a miss here that I just can really hope that we need the young entrepreneurs and the tech-savvy people and the business community to all interface in a new way with those of us in the trenches to look for solutions.
And I think I would wrap it up. I'm excited with the tech piece of it too, and this multi-digital platform that we're all on right now, that there's such a huge opportunity to get the education out there. And I think, you know, we are doing that, but we need to do it in a more succinct way and focus more on preventative care instead of treatment. Right?
So, aren't these women just absolutely amazing? So I know there's going to be lots of questions. There's a microphone here that we'd like people to come up to. They're not passing one on this one, so please come on up.
Okay, I'll go first. I was so lucky to suffer from hyperemesis gravidarum when I was pregnant, which is extreme nausea and vomiting throughout the 9 months that you're pregnant, which actually affects 1% to 2% of women. And when I met with the healthcare institutions and doctors, I really felt a belittling of that diagnosis. They were like, oh, you know what, it's fine, like, but we can't really do anything for you. They were super reluctant to prescribe any kind of medication, anything that could help. And they were like, maybe it's also psychological, like we don't really know. I was like, I'm throwing up 5 to 7 times a day. What do you mean this is psychological for 9 months straight? And so I was just wondering, in pregnant women, why is the research lacking? Is it because it's not possible to do the research when you're pregnant, or is it also a funding issue because the medical institutions have interest?
I can comment. And thank you for bringing that up, because that is a very important piece of this whole thing. You know, women were excluded, and pregnancies considered, you know, it's really just a major gap. Sick women get pregnant women get sick, and for some reason we're supposed to just tell them to stop all their medications for 9 months and hope for the best. So I think what happens is in order to successfully conduct a clinical trial, you have to go through all of this regulatory approval, and they make it very difficult to enroll pregnant women. It's possible, but they make it very difficult. So what happens is researchers are like, well, it's cheaper. I'll make sure we do pregnancy tests and make sure that they're not pregnant. I mean, we saw this with COVID and the vaccines. I was watching those trials very closely to see, and they specifically excluded pregnant patients. And if you became pregnant after the first and before the second, you were excluded. And so I think that if we actually look at the mechanisms in animal studies, and have good basis of data that we can then tell women, this is real informed consent. Like, we've done all of this. We know that the risks are minimal. We think that this might be beneficial. Then I think women will be entitled to feel like they could join a clinical trial. So that is something that is talked about at the NIH. I'm on the advisory committee for the Office of Research on Women's Health. But we have a long, long way to go.
But your point's really well taken, because if you look at drugs as they're going through the FDA, they really aren't we don't have data in pregnant women, and in fact what happens is the drugs are approved, and then we do a registry of pregnant women or women who get pregnant while they're on a drug, and that's where we get our data kind of hindsight. So we have very limited data for all the reasons that Dr. Mcgregor just said in pregnant women, and you're right, but across the board, not just in pregnant women, the funding for research in women-specific diseases, okay, so if we use cardiovascular disease, we just talked that there's very limited gender-specific research in women's cardiovascular disease, so that's a disease that affects both men and women. But when you look at women's-specific diseases and the amount of funding, endometriosis, polycystic ovary syndrome, fibroids, women's sexual health, the amount of NIH funding that's given to women's-specific diseases is vastly less. And that's another whole area, which is, if you want to get out there and write to your Congress people and raise awareness, and all of us do a lot of advocacy work, or try to do a lot of advocacy work on the Hill to try to, again, help with that disparity as well. But sorry you had that issue.
I was reading here, and if anybody else has another question, come on up, that despite 70% of the world's healthcare professionals are women, they're underrepresented at medical journals and leadership positions within medical research and practices. And how can that be fixed? That's a big question.
It really affects across the board, right? So the number of full professors who are women in academic centers, the number of deans, CEOs of health systems, the numbers that are so disproportionately low. And if you even look at the specialties that women are in, if you look across the board, women are in the lowest paying specialties in healthcare. And I would tell you radiology is a really good example, which is radiologists typically have high salaries. If you look at the lowest paid segment of radiology, it's breast imaging. And who does breast imaging but the women? And there's just, the disparities just go and go and go in that arena. I don't know how to fix it. We're trying.
Question?
Yeah, hi. I've heard in talking about the reason why there's not so much research about women's health, an excuse being given about the variability of a woman's cycle and hormones being difficult to conduct studies in that way. Well, first of all, is that true? Does that hold water? And then I guess as a follow-up to that, if you could provide more insight into the research that is done on female health, how is that conducted given that variability?
Sure, I can comment first. It's always been thought that women are more complicated to study, right? But they actually looked at that in animal studies and found that female mice were not more complicated to study than male mice. And so I think that's just been an excuse. However, most of our research has been done on a very hormonally stable subjects. So men in their 20s and 30s and 40s. Now testosterone also, changes throughout the day, it changes throughout the lifetime. Of course, estrogen also cycles throughout the lifetime and throughout the month. And so we've really ignored that, any sort of effect that we think that can happen. We now know that your estrogen receptors or your testosterone levels affect your ability to metabolize medications. It affects your ability to fight off infections, including COVID. So we do know that it really does matter. It matters for when you are taking certain medications. During certain times of the menstrual cycle, your medication can drop. And so for things like seizure, and so you might have a breakthrough seizure during your period, that sort of thing. None of that is discussed or talked about. So I think, in moving forward, I would say that we should be considering all of these aspects in our studies. So we can, I'm hoping technology will be able to, really look at where women are in their menstrual cycle if they're enrolled in a subject, or even testosterone, or what if they're taking exogenous hormones, what if they're taking pills because they're transitioning, or they're, for whatever reason. And so we really need to start to include that into our understanding of health and disease, because using the fact that we're too complicated because of that as an excuse is just, it's intolerable.
So you talked about Ambien as being a drug that has been learned retrospectively not to be as the best thing for women under the current dosage prescribed. And I think you talked a little bit about hormones, Dr. Larkin, and when I went through menopause, hormones were like, oh, no, and then all of a sudden they became yes, but that news was less available than the bad, right? So are there other drugs that we should be aware of, that there's been learning on them, that they may manifest differently in women than men, that people are probably taking here?
So for sure, it's rapidly evolving space. And back to your question, I think women are different than men, but from my perspective, the first and most important thing is we just have to really include them equally in trials, and we have to look at the data in a lens that's specific to their sex, right? If we look at the cholesterol-lowering medications, many of you may be on statins, right? The vast majority of data, even though we've started to enroll women in those trials, is really all in men. And in the same way that we looked at all of the aspirin data, and we only enrolled men in those early trials for looking at aspirin to prevent that first heart attack, in the same way most of the data about cholesterol medications preventing a second heart attack or preventing that first heart attack is really done in men. And we completely know that cardiovascular disease is different in women than men. Women have smaller blood vessels, they form plaque differently, and no surprise now when you start looking at the statin data in a sex-specific way and you try to tease out women data for statins versus men, wow, just like with aspirin, the data looks very different. And we don't have any gender-specific or sex-specific guidelines yet. And so I really think, the first and foremost thing is we really have to be much more mindful at making sure that we're enrolling women equivalently in the trials, and then really looking for all medications at really sex-specific differences, because Ambien, we're finding lots of that in post-marketing data for medications. Again, no surprise, women metabolize them differently. Where we have to get to ultimately is looking at reproductive stage of a woman's life, and if there's differences across their lifespan in terms of how they metabolize drugs, and that will all come. But I think right at this moment, we just need more women in trials, and then we can get better as we go forward, but we're starting from way behind right now.
Thank you. Question?
Hi, so first of all, I'd like to thank you all for being here. I'm a fourth year MD MPH student at the University of Washington, so it's great to see female physicians. I will say that your characterization as TikTok was a little bit stuck to my heart a little bit, because I just did a talk about how TikTok can be a great advocate for particularly Black patients that are looking at racial inequity. But your solutions in terms of women being educated and advocating for themselves in the clinician space, to me, those kind of seem inaccessible for Black women in particular, who, even if you are educated, even if you are powerful, advocating for yourself isn't something that is necessarily listened to. An example that I think of is Serena Williams, who's one of the most powerful women in the world, well known and still wasn't listened to when she advocated for herself. So what
Serena Williams, is that who you're talking about? Or?
Yes.
Yeah.
So what solutions do you have systemically for Black women where the idea of advocating for yourself, going to more appointments, isn't really a realistic solution?
I hear you, and basically it's just compounding biases, right? So if you are a gender minority or your sexual orientation minority or your race, your gender, your sex, the more of those you have, the more compounding the bias is. I think as far as advocating for yourself, one of the things that I tell patients and the public is that to be an advocate or bring one. So a lot of women especially will come in, and especially in the emergency department setting, which is where my examples come from, and they're in crisis. They didn't plan on being there. They're in pain. They don't feel well, and so what happens is they may not communicate that very well. And so when they have a friend, a partner, a relative, and that person says, "She doesn't normally complain like this. I know her chart says anxiety, but this is not her panic attack. Through COVID, it's difficult to have access to them, but I'll call family and friends, and I'll bring them into the examining room, even through the phone, just to help get a sense of someone else putting this in perspective to help with that person. So also just look for diverse workforces. You can't really choose your doctor in the emergency department, but when you do have the ability to choose a doctor, make sure that you're choosing one that has diverse physicians, diverse workforce, because that also has been shown to really, the more diverse the workforce, the healthier everybody is, because everybody's putting together their thoughts. So, those are a couple things I would suggest, and let's just keep at it, and when you have your sphere of influence as a physician soon to be, we could use your help.
I know what we've been doing, and we've always done, is like one size doesn't fit all, right? So we partner with a lot of other different organizations to make sure that we listen and understand how their followers, their audience would like the information, and we work together. So we're collaboratively working on national campaigns that, and have different modes of educational pieces, right? So a pamphlet might work well for one group, but it's more, maybe it's radio or a television ad for another group, or maybe it's all, could be TikTok or a different social media outlet that would work better, or all of the above. So it's always customizing and making sure that we understand the audience and the goals, and partnering with other organizations to make sure it's more powerful and has a longer shelf life and will get out to the audience that needs the information.
Do you mind if I say one thing? First of all, I want to celebrate you. Congratulations and good luck in your professional career. And I do want to say that I think that from my perspective, and this is really the second time or third time or 10th time I've done this, I think it's a miss when I sit here and talk about women's health, because we really should talk about African American women who really get even worse care than general women in the women's health space, and who, if we look at diseases that disproportionately affect African American women, fibroids being one, right? We know that African American women, it's really underfunded, and they don't get good care. And you're right, there's lots of barriers to that. If you think about breast cancer, it is different in African American women. They have much higher rates of triple negative disease. We don't understand the racial disparities in that. There's lots of work that needs to be done, and we aren't really doing a great job there either, and we should have much more specific focus on that. So I 100% hear you, and thank you for bringing that up. The other thing about the TikTok, so I just want to tell you that in the organizations that I'm in, as now one of the old physicians, right, who didn't grow up with social media and didn't grow up with TikTok, this is TikTok and all of the social media platforms for disseminating information. one of the things that we struggle with in our organizations is that it's unregulated information. So right as I talked, which is the problem is it's really impossible for consumers to sort out what's evidence-based information that's following guidelines versus what someone's opinion or what someone is profiteering off selling something versus information. And so for us in our national organizations, it's still something that we're struggling with, how to bring in younger generation in these social media platforms to do the right thing to get the information to the consumers that need to get it, because I think you're right, we are missing vehicles to transmit good information because we're uncomfortable using those social media platforms because it's unregulated and because we don't have the money. So in our nonprofit professional organizations, we don't know how to access that yet in the right way. So again, if anyone here has ideas on how to help us do that correctly, I would love to talk to you.
I think that was
So would I.
It's going to have to be our last question, unfortunately.
Sorry.
Sure. Hi, Ira Horn, also physician. I typed my medical school application as well.
So you didn't grow up with TikTok either.
So I didn't grow up with TikTok, but I have to speak up because I'm so proud of this generation and the work that they're doing. I think there are a couple of things that we have to think about in our generation, because now I sit at the intersection of tech and health, is these partnerships and collaborations and understanding and learning from the new generation in how they get information. And oftentimes we do the same things in public health that we did when I was in training, which is a pamphlet, which is putting something on a billboard. But there are ways to make public health public, and it's a matter of partnering with organizations and young people so that one of the great examples is what happened in YouTube when we partnered things with like Dr. Fauci, with people who were like hip hop artists. But it's like getting information in a way, because it's like the message and the messenger, and who are the trusted advisors who are providing that information. We learned a lot during the pandemic around the importance of, it's not just the messenger, it's not just the message, it's also the messenger. And so I think our opportunity is to say, hey, we know something, can we share that with you? And share it with our community and sphere of influence, and with the American Academy of Pediatrics, Society of General Internal Medicine, coming together to do that work. And I think it is really important when we're passionate about this work and this intersection of race, ethnicity, gender identity, to bring all those pieces together to have a conversation. So thank you all so much for what you're doing and the work that you're doing around women's health, and making sure that we're including all people who identify as women as part of that conversation.
Yes.
Yep,
Thank you.
That's great. So I really want to thank everybody for such a wonderful panel, and I really want to thank our guests, Dr. Larkin, Dr. McGregor, and Beth, for joining us here today in this great panel. I think there's been a great discussion. I really want to walk away and saying that women's health and gender bias is not just a women's problem, it's not just an African American women's problem, and it's all our problem, because it's a better society when we're all healthy. So thank you for joining us here today. We're going to show the trailer if you guys have a few more minutes while we're exiting. It's really good. I just don't know how to press the right button.